or dopamine pathway in schizophrenia. The mesolimbic dopamine pathway projects from the dopaminergic cell bodies of midbrain ventral tegmental area of the brainstem to the axon terminal of nucleus accumbens, a part of the limbic system of the brain thought to be involved in many behaviors such as pleasurable sensations, the powerful euphoria of drugs of abuse, as well as delusions and hallucinations of psychosis. The mesocortical dopamine pathway, a pathway related to the mesolimbic dopamine pathway. It also projects from the midbrain ventral tegmental area but sends its axons to areas of the prefrontal cortex where they may have a role in mediating negative symptoms, where they may have a role in mediating cognitive symptoms, dorsolateral prefrontal cortex, DLPFC, and affective symptoms, ventromedial prefrontal cortex, VMPFC, of schizophrenia. The nigrostriatal dopamine pathway, which projects from the substantia nigra to the basal ganglia or striatum, is part of the extrapyramidal nervous system and controls motor function and movement. The fourth dopamine pathway of interest, the tuberoinfundibular dopamine pathway, projects from the hypothalamus to the anterior pituitary gland and controls prolactin secretion. The fifth dopamine pathway arises from multiple sites, including the periaqueductal gray, ventral mesencephalon, hypothalamic nuclei, and lateral parabrachial nucleus, and it projects to the thalamus. Its function is not currently well known. The therapeutic actions of conventional antipsychotic drugs are hypothetically due to blockade of D2 receptors, specifically in the mesolimbic dopamine pathway. This has the effect of reducing the hyperactivity in this pathway that is postulated to cause the positive symptoms of psychosis. All conventional antipsychotics reduce positive psychotic symptoms about equally well in schizophrenia patients studied in large multi-center trials if they are dosed to block a substantial number of D2 receptors there. Unfortunately, in order to block adequate numbers of D2 receptors in the mesolimbic dopamine pathway to quell positive symptoms, one must simultaneously block the same number of D2 receptors throughout the brain, and this causes undesirable side effects as a high cost of doing business with conventional antipsychotics. Although modern neuroimaging techniques are able to measure directly the blockade of D2 receptors in the dorsal, motor, striatum of the nigrostriatal pathway, for conventional antipsychotics it is assumed that the same number of D2 receptors is blocked in all brain areas, including the ventral limbic area of striatum known as the nucleus accumbens of the mesolimbic dopamine pathway, the prefrontal cortex of the mesocortical dopamine pathway, and the pituitary gland of the tuberoinfundibular dopamine pathway. Neurolepsis. D2 receptors in the mesolimbic dopamine system are postulated to mediate not only the positive symptoms of psychosis, but also the normal reward system of the brain, and the nucleus accumbens is widely considered to be the pleasure center of the brain. It may be the final common pathway of all reward and reinforcement, including not only normal reward, such as the pleasure of eating good food, orgasm, listening to music, but also the artificial reward of substance abuse. If D2 receptors are stimulated in some parts of the mesolimbic pathway, this can lead to the experience of pleasure. Thus, if D2 receptors in the mesolimbic system are blocked, this may not only reduce positive symptoms of schizophrenia, but also block reward mechanisms, leaving patients apathetic, anhedonic, lacking motivation, interest, and joy from social interactions, a state very similar to that of negative symptoms of schizophrenia. The near shutdown of the mesolimbic dopamine pathway necessary to decrease the positive symptoms of psychosis may contribute to worsening of anhedonia, apathy, and negative symptoms, and this may be a partial explanation for the high incidence of smoking and drug abuse in schizophrenia. Antipsychotics also block D2 receptors in the mesocortical dopamine pathway, where dopamine may already be deficient in schizophrenia. This can cause or worsen negative and cognitive symptoms even though there is only a low density of D2 receptors in the cortex. An adverse behavioral state can be produced by conventional antipsychotics, and is sometimes called the neuroleptic-induced deficit syndrome because it looks so much like the negative symptoms produced by schizophrenia itself. Extrapyramidal symptoms and tardive dyskinesia. When a substantial number of D2 receptors are blocked in the nigrostriatal dopamine pathway, this will produce various disorders of movement that can appear very much like those in Parkinson's disease. This is why these movements are sometimes called drug-induced Parkinsonism. Since the nigrostriatal pathway is part of the extrapyramidal nervous system, these motor side effects associated with blocking D2 receptors in this part of the brain are sometimes also called extrapyramidal symptoms, or EPS. Worse yet, if these D2 receptors in the nigrostriatal dopamine pathway are blocked chronically, they can produce a hyperkinetic movement disorder known as tardive dyskinesia. This movement disorder causes facial and tongue movements, such as constant chewing, tongue protrusions, facial grimacing, and also limb movements that can be quick, jerky, or choreiform, dancing. Tardive dyskinesia is thus caused by long-term administration of conventional antipsychotics and is thought to be mediated by changes, sometimes irreversible, in the D2 receptors of the nigrostriatal dopamine pathway. Specifically, these receptors are hypothesized to become supersensitive or to upregulate, i.e., increase in number, perhaps in a futile attempt to overcome drug-induced blockade of D2 receptors in the striatum. About 5% of patients maintained on conventional antipsychotics will develop tardive dyskinesia every year, i.e., about 25% of patients by 5 years, not a very encouraging prospect for a lifelong illness starting in the early 20s. The risk of developing tardive dyskinesia in elderly subjects may be as high as 25% within the first year of exposure to conventional antipsychotics. However, if D2 receptor blockade is removed early enough, tardive dyskinesia may reverse. This reversal is theoretically due to a resetting of these D2 receptors by an appropriate decrease in the number or sensitivity of them in the nigrostriatal pathway once the antipsychotic drug that had been blocking these receptors is removed. However, after long-term treatment, the D2 receptors apparently cannot or do not reset back to normal, even when conventional antipsychotic drugs are discontinued. This leads to tardive dyskinesia that is irreversible, continuing whether conventional antipsychotic drugs are administered or not. Is there any way to predict those who will be harmed with the development of tardive dyskinesia after chronic treatment with conventional antipsychotics? Patients who develop EPS early in treatment may be twice as likely to develop tardive dyskinesia if treatment with a conventional antipsychotic is continued chronically. Also, specific genotypes of dopamine receptors may confer important genetic risk factors for developing tardive dyskinesia with chronic treatment using a conventional antipsychotic. Risk of new cases of tardive dyskinesia in elderly subjects may be as high as 25% within the first year of exposure to conventional antipsychotics. However, if D2 receptor blockade is removed early enough, tardive dyskinesia may reverse. This reversal is theoretically due to a resetting of these D2 receptors by an appropriate decrease in the number or sensitivity of them in the nigrostriatal pathway once the antipsychotic drug that had been blocking these receptors is removed. However, after long-term treatment, the D2 receptors apparently cannot or do not reset back to normal, even when conventional antipsychotic drugs are discontinued. This leads to tardive dyskinesia that is irreversible, continuing whether conventional antipsychotic drugs are administered or not. Is there any way to predict those who will be harmed with the development of tardive dyskinesia after chronic treatment with conventional antipsychotics? Patients who develop EPS early in treatment may be twice as likely to develop tardive dyskinesia if treatment with a conventional antipsychotic is continued chronically. Also, specific genotypes of dopamine receptors may confer important genetic risk factors for developing tardive dyskinesia with chronic treatment using a conventional antipsychotic. Risk of new cases of tardive dyskinesia, however, can diminish considerably after 15 years of treatment, presumably because patients who have not developed tardive dyskinesia despite 15 years of treatment with a conventional antipsychotic have lower genetic risk factors for it. A rare but potentially fatal complication called the neuroleptic malignant syndrome, associated with extreme muscular rigidity, high fevers, coma, and even death, and possibly related in part to D2 receptor blockade in the nigrostriatal pathway, can also occur with conventional antipsychotic agents. Prolactin elevation. Dopamine D2 receptors in the tuberoinfundibular dopamine pathway are also blocked by conventional antipsychotics, and this causes plasma prolactin concentrations to rise, a condition called hyperprolactinemia. This is associated with conditions called galactorrhea, i.e., breast secretions, and amenorrhea, i.e., irregular or lack of menstrual periods. Hyperprolactinemia may thus interfere with fertility, especially in women. Hyperprolactinemia might lead to more rapid demineralization of bones, especially in postmenopausal women who are not taking estrogen replacement therapy. Other possible problems associated with elevated prolactin levels may include sexual dysfunction and weight gain, although the role of prolactin in causing such problems is not clear. The dilemma of blocking D2 dopamine receptors in all dopamine pathways. It should now be obvious that the use of conventional antipsychotic drugs presents a powerful dilemma. That is, there is no doubt that conventional antipsychotic medications exert dramatic therapeutic actions upon positive symptoms of schizophrenia by blocking hyperactive dopamine neurons in the mesolimbic dopamine pathway. However, there are several dopamine pathways in the brain, and it appears that blocking dopamine receptors in only one of them is useful, whereas blocking dopamine receptors in the remaining pathways may be harmful. The pharmacologic quandary here is what to do if one wishes simultaneously to decrease dopamine in the mesolimbic dopamine pathway in order to treat positive psychotic symptoms theoretically mediated by hyperactive mesolimbic dopamine neurons and yet increase dopamine in the mesocortical dopamine pathway to treat negative and cognitive symptoms, while leaving dopaminergic tone unchanged in both the nigrostriatal and tuberoinfundibular dopamine pathways to avoid side effects. This dilemma may have been addressed in part by the atypical antipsychotic drugs described in the following sections, and is one of the reasons why the atypical antipsychotics have largely replaced conventional antipsychotic agents in the treatment of schizophrenia and other psychotic disorders throughout the world.